Hello, I'm Juan Muro, physiotherapist, and I'll discuss a clinical case of a patient with a hamstring tear, specifically at the distal myotendinous junction of the biceps femoris on the left leg. This level is also often referred to as a zip tear. It entails a fascia separation of the short portion of the biceps. It's a very common injury, especially in football players. It is important to do a good diagnosis and palpation and effectively assess the condition of the tissue. Normally it's a tissue that's more contracted, more rigid, a tissue that when you ask the patient to bend the knee creates symptoms, even when stretched as well. If we have the option and knowledge with an ultrasound, we can objectively assess the type and extent of rupture or edema to make a real prognosis and effectively prove that it is a rupture at that level. We also have patients who often seem to have ruptures in this area, but they're often functional problems. In other words, the patients have no expected pain or contraction. The stretching doesn't give very clear aspects, but the patient describes that they can't perform the sport well, since one leg feels different from the other. This should trigger a spark at the diagnostic or examination level, and also our clinical reasoning so we can bring resources to the patient. There's no need to wait until injury to use X signal technology to benefit or generate resources. Let's remember above all that we can improve functionality, performance and sports performance. We can use program 5, which will be explained at the end of each video, with a breakdown explaining what each program can do for your patients. So let's go to our patient. We're treating a somewhat local, objectifiable, positive contraction, stretching, functional rupture. We can also do a monopodal squat, an eccentric movement. We can also do an ultrasound. And I'd place the first electrode locally for the myotendinous junction at the distal level, in that separation of the short and long portion of the biceps. For example, in an acute stage with a lot of symptoms, we can use program 6. If you want to generate more resources regarding the autonomic nervous system and there's no rupture, program 7. Great. It's great for performance. I put it here directly on the patient. Now the X signal device is running. We'll switch to program 3 for posterior structures. I'll mainly focus on manual therapy. It's essential for manual therapy to be as active as an integrating element. With Nesa technology, it's essential to work the gluteal region in hamstring and posterior region injuries. We could see other cases such as in the calves, such as a pathology of the Achilles tendon or plantar fascia. The origin, well, the problem is proximal. The upper limbs, the scapula, the lower limb, hip, gluteus, gluteal region and gluteal crease. It's called a crease because it's very narrow anatomically. The nerve is very long and must bend and run through creases, and so the risk of injury is greater. Therapeutic action, whether manual or with technology such as directional electrodes, is therefore key. So I'm doing local work. I'll do a cleansing mainly of the pulvitrocanteric muscles, everything below the pyramidal muscle, the superior geminus, obturator internus, inferior geminus, quadratus femoris, which are all essential. Work all these muscles, work the lower edge of the gluteus maximus, techniques for lifting the gluteus maximus. Why? Because it helps proper sliding of the planes and information flow. So while I'm working on this system, I have X signal technology at program 3, which normalizes all the information that's key. In clinical reasoning, it's important to consider functionality. It will always be a functional pathology. What is a functional pathology? It's a pathology of information, of electrical activity, and we need to work on that. Once the entire gluteal crease is worked on, cleaned and normalized with manual therapy, we'll then use our key approaches with a directional electrode for the hamstring injury. Where should I go? I'd go primarily to the posterior ischium edge, placing it approximately 3 finger widths proximally and a little bit medially. There's the sciatic spine, where the sciatic nerve comes out. It will work the sciatic nerve, giving me a lot of resources regarding hamstring functionality. Mainly the posterior chain, the sciatic nerve is the posterior chain, but we're talking about the hamstrings. I could work manually, locally at this level, separating the septa, mainly of the long portion of the biceps with the semitendinous, of the vastus externus with the long portion of the biceps, and so on. To gain this functionality, mobility, for example, of the hip joint. I've already mentioned that the hip is also a fundamental biomechanical element of the lower limb. So, the sciatic nerve, hip, we have to play with all of this. A further key element, working with Nesa non-invasive neuromodulation. I would primarily work on another spot right at the ischium posterior edge, lateral this time. It's essential to work the lateral edge of the ischium. Why? Because anatomically the sciatic nerve rests on that branch. So we'll have to work at that level. I'll place the electrode. I'll put the electrode here and work at this level. I could work, for example, with the sacral sciatic ligaments or with manipulation techniques on the sacrum. I'll improve resources in this whole system. So it's important to know that this is a structured pathology, a functional pathology. As always, as long as it's an objectifiable injury, there'll be no functional pathology. It's essential to normalize that functionality. We're talking about the functionality of that system, which is aqueous, fibrous, and neural. There are many therapeutic possibilities. Adapt to the patient. Another very frequent pathology we treat at the clinic regarding the pelvic floor area concerns the pudendal nerve. How can I locate this pudendal nerve? At the level of the directional electrode. Well, it's the same thing. Central point. As we've seen in this video, the posterior edge of the ischium. At the posterior edge of the ischium, we drop medially, this time inwards. We'll go here. The pudendal nerve runs the entire pudendal canal via the obturator internus fascia. It's the obturator internus, the hip. Remember the influence of the hip on pelvic floor pathologies. Here we'll place the medial directional electrode. We lift, place the electrode, and we have it constantly working on that pudendal nerve. Okay. We have multiple and varied therapeutic options. Technology highly adapted to all patient types. It makes no difference whether the patient is a bank clerk, an elite footballer, elderly, or very young. The combination of sound anatomical knowledge, a thorough examination, and a proper diagnosis allow us to establish the right program and treatment for the patient. As always, thank you all for watching. And thanks to everyone here behind the camera. It's been a pleasure to share my knowledge, and I hope you continue following the clinical cases that we have on our approaches using the X signal device on our patients here at the clinic, which has been highly successful. Again, I'm Juan Muro Zabaleta.